تمام. اوكي. انا كده shared everything is appearing in front forward صح؟
نعم واضح.
اوكي كده كويس قوي. اوكي. انا هبدا بالموضوع اللي الدكتور نور الدين كان هيكمل عليه، اللي هي structural heart disease ventricular tachycardia ablation. My idea will be more concise about the tips and tricks of getting less complication, getting more results, and better option for success. The idea how to reach the success with less complication and less time consuming, and at the same time to find the best option for every patient. It should be individualized more than like all the patients I will do the same procedure for them. It will be variable according to what we see. Okay. The first part we'll talk about, it will be the mapping itself. All the time it will be challenged, sometimes hemodynamic instability because of the ventricular tachycardia, sometimes intolerable. So other options that I have discussed before about the substrate mapping, types of mapping that we use to get more better data of the information of the heart itself, left ventricle or right ventricle according to the disease itself. The idea of the outcome, ventricular circuits that could be impossible to be mapped, or mapping of them that can mask another types of other surrogate clinically or sometimes not clinically documented ventricular tachycardia that can be present all the time. Okay. Okay. The idea of structural heart disease and what should I do? Okay. According to the Decrement, he discussed how to manage everything. If we're talking about ICD, it is the main rule of the management in all the patient to prevent sudden cardiac death. And ablation is just add on to prevent the recurrence, to prevent how much consuming of the ICD itself, and to reduce the incidence of ventricular tachycardia that needs much antiarrhythmic drugs of high dose or something like that. And this is the indication that we can make like a mapping protocol that should be mapped according to we have seen here. Okay. Mapping strategies and ablation. Okay. Mostly ablation itself will get some data that we'll talk about. Okay. Mapping and sinus rhythm, TBS mapping, ventricular tachycardia, 3D mapping, all these ideas. Then we have linear lesions, short lines, conduction channels and dechanneling, lead potentials, and the entrapment mapping. And all the one can be add on or can be one according to which patient that we need and how much will get result from the ablation itself. And according to the success rate that we have seen, according which point can be add on and increase the success rate. So strategies according to the type of the structural heart disease itself. For example, ischemic cardiomyopathy, most probably it's subendocardia, as Dr. Nuruddin have mentioned, and distribution mostly focal according to the territory of the artery itself, and most probably we use endocardial ablation, late sometimes to be epicardial. Non-ischemic cardiomyopathy, most probably it's mid myocardial or epicardial, and scar distribution is patchy, so you will need much more mapping of the heart itself to get to the best option that we can get, especially the site is basal anteroseptal or infralateral LV region, especially near the mitral annulus. And all the time you will need endocardia from the start, then add on epicardial according to the results. Arrhythmogenic right ventricular dysplasia, it's most probably subepicardial and it's batch distribution. So all the time you are mapping the right ventricle, but sometimes you will need to map left ventricle in some conditions. Cardiac sarcoidosis, it's rare to find it here, but sometimes you can find it. And at the same time, it's endocardial, epicardial. Most probably it's basal and the mid-intraventricular septal. Hypertrophic obstructive cardiomyopathy, which is the most difficult one, and it's all the time LV apex and the aneurysmal area, sometimes in the septum itself, and we use different technique of ablation like alcoholic ablation. Chagas disease, I haven't seen in my life except one case, so I will not be more data about it. Okay, So let's get to the tips of the tricks that we can find for every mapping technique. For example, if I'm talking about base mapping, I started to make mapping of the patient and I will do base mapping for them. So I need to reach what's called the ideal match. Like base QRS morphology is completely matched with the clinical VT. But is it actually that we have reached this 12 by 12? That depends on 3 points of view. Like you are basing with how much power. For example, if you are getting much power, you will get capture of large myocardium. So can give you more pattern of 12 by 12 ideal match, but actually you are capturing much myocardium that getting this result. So it should be less power with localized point of basing. So to find which the best point that you are based at. Stimulus to QRS interval. The site with the stimulus to QRS latency more than 80 milliseconds is more likely to be an ablation target. If it's shorter, you are near to the exit point. If it's very far, like more than 80 milliseconds, you are maybe in dead loop or, for example, inner loop that's far from the site of ablation. Within 70 milliseconds, it's more apparent to be in the isthmus itself or entrance zone. You should, when you are doing basing, you should do the same cycle length as the documented clinical ventricular tachycardia, so you can get better match with the documented VT. Okay. When you are in the true isthmus and you are basing from the site near the entrance, the isthmus, you will find with long stimulus to QRS interval. This can give different QRS morphology because there is different capturing of antidromic wavefront with orthodromic wavefront. So it should not be so much matched, but this can be the entrance of the isthmus itself. So it should be also a line of the ablation site. But you need to be more accurate about is it different site of clinical EVT or not. Because during the basing itself can give you different morphology, like for example, 11 by 12 or 10 by 12, and can be part of the circuit itself. So if you are not getting the ideal match, this means it's not a good site of good ablation. No, it can be site of ablation, but just evaluate how much it's reading or comparable to the clinically documented VT. Sometimes the absence of functional block during base mapping, especially under sinus rhythm, can also produce different QRS morphology. So if you find different morphology, you can be in the outer loop or maybe, for example, near the loop or near the isthmus, but you are in the entrance zone, so you are getting some different morphology. So this should be put in mind. Okay. During substrate mapping, it should be when you are doing the substrate mapping and you have identified the points of late potentials or lava, is it actually this is what I have got or something different? So you are doing what's called basing maneuver to identify and characterize the conduction property within the scar or border zone. Like for example, you have made substrate mapping and voltage mapping and find the area of the scar and find the area of the border zone, and you need to identify is it actually this is border zone or scar zone. So you try to base the failure to capture, especially if you are good contact with the tissue, can give you provide information about fixed conduction block. It means that this is actually scar area. So this is good information about it. Fixed conduction border, especially if you are trying to make linear lesions to make blocking of the isthmus itself. So when you are already got the substrate mapping, you try to base with, for example, larger amplitude of power to get capturing. If you are failing the capture and you are good contact with the tissue, this gives you information about, yes, this is scar zone. So I will use it as, for example, block lines in between to get what's called linear lesions. If I got detection of late potential, this is sometimes misleading if you find that actually I have found this fracturated potentials and I am not sure is it near or not. So you are trying to get the slow conduction area and the direction of the activation waveform. For example, if you are mapping during sinus rhythm and mapping during, for example, RV basing. It will get you different morphology and different late potentials. So you must put in mind, try to base sometimes and map also in the sinus rhythm to be sure this is potentials are lava or late potentials, to get it in mind when you are substrate mapping. So during substrate mapping, after, for example, in sinus rhythm we have mapped, try also to base ventricle, RV ventricle, and try to map the same area again to identify late potentials or, for example, fractionated EGM. In case of the slow conduction area, when you are located in the septum, sometimes you can find fragmented potentials buried within the QRS complex. Is it actually fractionated potentials, or it may be Purkinje potentials that can give you the same pattern as late potentials or fractionated potentials? What we should do, you should base at this area, for example, from the RV basing, and try to find if this potential is getting late or it's fixed. Because Purkinje fiber potentials, it will be fixed during the QRS complex, just a far field or near field. It will not change the pathology position. But if it's fractionated potentials and you are thinking that it may be late potentials or due to scar, you will find these potentials are getting late during sinus compared to, for example, during RV basing. So when you are trying to make substrate mapping in the septum in patient, for example, past inferior anterior MI or septal MI, you are trying to be sure if these potentials are Purkinje fiber potentials or late potentials or fractional potentials of scar tissue. Okay. Sometimes you will find it very sharp potential, high frequency potential that's observing during the QRS complex itself. Sometimes, as I said, it may be potential of Purkinje fibers. Sometimes these Purkinje fibers are substrate itself and should be mapped and ablated sometimes, especially in the distal septum. For example, you are mapping the apical zone or apicoseptal area. These potentials are very sharp near the QRS complex itself, and maybe sometimes preceding the QRS during sinus rhythm. Sometimes this can be potentials for ablation, especially, for example, in extrasystole that getting from this area and inducing the tachycardia itself. So they are not all the time like potentials you're not getting to ablate. No, sometimes you need to ablate them if you are thinking these potentials are the origin of extrasystole that can induce the ventricular tachycardia. And this time you will do extra stimulation from this area to provide the QRS complex morphology of the BVC that documenting during the tachycardia itself or during Holter study or something. Okay, this is good way to identify the potential that you have got. Is it, for example, far field lead potentials, and you want to know if these potentials are good substrate for ablation or just they are not significant for them. It's simply you are trying to identify these potentials, lead potentials, for example, or fractionated potential, and you are doing extra stimulation. For example, you do a train and then extra stimulation with shorter interval, and you find this EGM or lead potential. If they are getting more late, about 10 milliseconds more, these are maybe very good points for ablation and the target for better ablation, because they are getting, as in the isthmus line, who are getting slow conduction or functional block during pacing that can induce the tachycardia in the late zone, as we are doing here. In this case, we are pacing, then suddenly developed ventricular tachycardia because of the functional block that happened, because of the delay, and sudden induction of the tachycardia. So if you are finding this potential in the scar zone and you are trying to be sure if this are the corridor or isthmus, you are doing what's called decremental evoked potential by extra stimulation from the RV itself, and define if they are getting delay more 10 milliseconds in the S2 or S3 or something, these good points for ablation and should be ablated. For example, this case, and we are doing voltage mapping and, for example, late potential mapping, then what's called decremental evoked potential. It's simple in the window. You will find in the window itself, like you are doing extra stimulation and you're doing the window late part of the QRS complex up to, for example, 30 or 40 millisecond after the end of the QRS complex. And you are trying to evaluate these points. And as long as the late one, you will capture it and put it in the window of interest. Then after that, you will put it as a point. When you find it at the end, you will find good new map about what's called decremental potential. And you'll find this area. These are the best points that you ablate and get good results as think like they are the isthmus itself. As we are seeing here in the S1 stimulation, we find this potential. The second one, after the second stimulation, you'll find it's very far of the QRS complex up to 151 millisecond. This is very far. So they are indicator that can be part of the circuit with functional block during extra stimulation. Some technical issue you must be very important about it. Contact of the tissue. Sometimes you are trying to map, and after mapping you find, oh, this good potentials, they are fractionated and something like that. And it's actually, you are poor contact. So to identify that for tips and tricks, as I said, you have scar area, low voltage area, and the normal tissue. When you are in poor contact or good contact, you will find the scar didn't change much. But while in the low voltage area, you will find in the poor contact, the potentials are low. But when good contact, you will find better signals like far field. In normal, and this is sometimes commonly to happen, you got bad like fractional potential, and when good contact, the potential becomes very good this area. So how to identify it? It's better to use, for example, smart touch catheters that you find that how much it measures the pressure area. Like for example, all the time, if you are using, for example, smart touch catheters, it will give you how much pressure near contact of the tissue. Is it 5 grams or something like that? It's better to be more than 5 up to like 15 or 20. This is the zone that you will find window of interest that give you that you are in good contact with the tissue. Also, is it, for example, the vector of the contact? Is it perpendicular or parallel? We all the time try to be more perpendicular to get good contact of the tissue. When you are parallel, it can give you local potential that are fractionated. Actually, it's not the true one because of the touching of the myocardium itself. So try to be all the time the vector of the smart touch, for example, more perpendicular, better than using parallel one. And for example, if you are using non-steerable sheath, it's better to use a steerable sheath like a Gelis or something like that. It gives you better like steering of the catheter itself and giving more contact tissue, especially in some areas that are difficult to be reached using simple non-steerable sheaths. Okay, let's talk about, you have identified the potentials, the lava, the extrasystoles by all the maps that we have said about. So now I am getting to the ablation. What's my target? You need to identify the target. And this should be according to every patient. So it's individualized protocol, like strategy. Every patient has its own protocol according to the form. Like for example, I have a patient, I have mapping. For example, it's tolerable VT, so I will do activation map and the base mapping of the VT documented for me. And at that point, I will use, for example, activation map and identify the isthmus itself by entrainment mapping and concealed diffusion, and I will ablate. If this is the end point, no. Sometimes not. This is the end point. You will add more strategies to get better success of the ablation itself. Like for example, I will use D-channel, I will use core isolation, I will use what's called scar zone and the border zone identification and ablation. Sometimes what's called homogeneous ablation. That's all defined according what I have seen. And clinically, what did the patient give you? For example, the patient has ICD and they have documented different clinically VT, like VT slow, VT fast, different types. For example, you have a patient with more VF than VT. So your strategy will be totally different. So according to the patient itself, the myocardium, how much scar you have got during voltage mapping, and how much you can ablate during the procedure itself without, for example, complication or side effect later on. So I will now identify ablation strategy according to the patient itself and how much myocardium will get scar. So, for example, what's called core isolation. First, I isolate dense scar by voltage mapping and do what's called circumferential ablation. Like, for example, I have a small scar in the apex, for example. I will do what's called the circumferential ablation. I ablate the zone itself so I can make it blocking, fixed blocking of this scar from the whole myocardium. And this is area should be like I identified the border zone from 1 millivolt and from 0.5 to 1.5 or sometimes 1 millivolt. So I will target this area by giving ablation at this point. And here you can identify the early entrance circuit, if possible, isthmus entrance or exit sites by either base and entrainment. Successful core isolation, it's defined by non-inducibility at basing output of 20 milliampere at point of 2 milliseconds from multiple sites within the core isolation area. So I identified the scar zone. I will ablate inside the scar zone by islets or, for example, lava points or late potentials, and I will make circumferential ablation of the border zone itself. The goal will be cover the entire scar, and always it's in limited small scar size. Okay, targeting abnormal electrograms as more documented during mapping. So this will be the best option for me in this case. Small scar identified, like localized in coronary artery territory, for example, or patchy points, I can ablate with this strategy. Other strategies that, for example, I have late potentials and lava, I will identify them during, for example, sinusoidalism and RV basing and identify them. Then I will do ablation of these points all the time. For example, the lava and late potentials in all areas, either in different scar zones. For example, I have large scar affecting the myocardium. I will map them all in the scar zone and I will make ablation of the late potentials and local abnormal ventricular activities. Both of them. And that will be what's called homogenization. So I will do extensive and diffuse ablation of the scar zone. So making what's called these functionally blocked zones into what's called fixed block zones by making ablation of all these points. So I make the scar like more homogenized, more scar zone, not there is islets of living tissue inside the scar zone, so they are not, could be a corridor or isthmus for other ventricular tachycardia that can be in. Sometimes it can be difficult to achieve in large scar zones or in, for example, near the mitral isthmus because it can be the scar zone very large and so difficult to be ablate. But you are trying to confirm them by every time you have ablated, you will do another mapping by capturing to this point that you have ablated already and try to get capturing. If not captured with 20 milliampere from these zones, you are getting good results about ablating these points. So you are trying to get earlier late potentials by ablation, and after mapping, you try to what's called the evoked potential, like excess all the time, and identify them and identify the zone that can be a corridor or isthmus for different ventricular tachycardia can be got. This ablation strategy is very extensive, so it can take 3 or 4 hours according to the scar zone that you have mapped. So try to be, if it can be limited by time, it's better to be used. As for example here, there is another technique if homogenization is difficult, especially in large scar, what's called the scar dechanneling. So I identified the channels that can be an substrate for ventricular tachycardia and they try to ablate either in the entrance zone, isthmus zone, dead points, for example, inner loops, exit points. I will do ablation at all these areas and try to remapping again. So all the idea, I will do the scar and do evoked potential, identify the scar zone that can be, for example, as a corridor or isthmus, and I try to ablate all the point from the entrance to the exit with the scar inside, so I can ablate all this area and make the channels de-channeled. So if if I got, for example, 6 or 7 channels, I can ablate them either from the exit point, entrance point, and the isthmus zone. And this can be done by the same idea of the substrate mapping by voltage and the width is at 0.5 up to 1.5, and the zone in between 0.5 up to 1.5. This is the zone that can be as a corridor or isthmus to the ventricular tachycardia that even not documented, but it can be used or can be indicator for different morphology VTAC that can be happening. And this, for example, this is a case. I have mapped by voltage here. Then, okay, and I identify different corridor and they make extensive ablation. Then I have made the voltage mapping later on in the figure of D, for example. In this case, you will find that these areas I have made all non-functional by fixed block. As we can, the voltage here becomes less than 0.5. Okay. So after ablation, and this is common that will happen, after you got ablation, either by de-channeling, core isolation, homogenization, you need to do another voltage map of these areas to find that you have made what's called fixed block and less than 0.5 millivolt. And try after ablation, you do base mapping with 20 milliampere at 2 milliseconds to identify if it is captured or not. So you got good block of this zone and becomes non-viable tissue, so it cannot get capturing of this zone or it can be scar zone again. So different techniques, as I said before. For example, in HOCM, hypertrophic obstructive cardiomyopathy, we can be what's called transcoronary ethanol ablation. Sometimes bipolar radiofrequency, and this is sometimes can be used in intramyocardial scar zones, especially, for example, in sarcoidosis or in ERD. Sometimes you need what's called bipolar radiofrequency from endocardial and from epicardial, try to ablate. Intramural needle ablation, I haven't seen before. And the lately, autonomic modulation. And this is sometimes can be used in ischemic cardiomyopathy with autonomic dysfunction, and all the time when there is short, long cycles and the induction of VTAC. So modulation of the autonomic nervous system can be used for this case by what's called sympathetic denervation. So what's the complication that can happen during the procedure? So even if you are doing the ablation and strategies of either different types, you must be careful about the complications that can happen. For example, vascular injury, either during access or during ablation, thromboembolic, and this is very important, especially if you are ablating inside the left ventricle, endocardial, sure, cardiac tamponade, and this is sometimes happened if you are doing, for example, epicardial access or during ablation itself and making perforation, for example. So the power should be identified according to the thickness of the scar itself and the zone that you are ablate. Either you are ablating in the left ventricle or in the right ventricle, for example, epicardial, endocardial, how much irrigation you are giving. This all should be identified from the start, and how much you are getting to avoid complication. Okay, so the vascular injury, we know mostly how much can induce hematoma, pseudoaneurysm, AV fistula, should be evaluated. Okay. What are the precautions that should be in our mind? Orientation of the anatomy, anticoagulation, especially during left side ablation, and heparin should be given. For example, my protocol, I will give heparin every 30 minutes, and measure the ACT accordingly, I will give the amount of heparin. And it should be from 250 to 350, and the better should be 300. This is the target all the time. Irrigation catheter to make surface cooling, and all the time try to get better irrigation with less impedance change. For example, all the time try to get, when you are irrigating, try to make, for example, 17 ml. You can reach up to 25 or 26 ml, or sometimes 30 ml during ablation. But this should be according to the scar zone, especially if you are in the left ventricle, and how much fluid you will give to avoid hypervolemia for the patients. How much you identify, is it apical septal, or you are targeting which points you are ablate. Coronary angiography, if ablation near coronary arteries ostia. And the ice, it's interestingly can be used, especially if you are ablating near the, for example, the base of the papillary muscle, the tips of the papillary muscle. Ice will give you better stability during ablation and can identify how much you are trying to give, and also identify if there is emboli or thromboembolism are produced, or for example, PUPS can happen, and this should be identified during ablation to avoid embolic, thromboembolic complication when you are doing ablation. Okay. This is the protocol for heparin that I give all the time. I'll start by 100 units per kilogram, then identify the different amount, either if infusion or by bolus, according to what I have seen during the ACT measurements. This, for example, ice during ablation, how much identify the point and how much the stability of the catheter that I identify. Okay. These are the complications that I'm talking about. Let's, for example, the precautions. Flushing. This is very important during, for example, transseptal puncture. Sometimes we are not good flushing. Should be good flushing during catheterization all the time to avoid air embolism. Energy titration. In the thin wall structure, try to less radio frequency power with impedance decreased less than 18 ohm when you are during ablation. If it's getting change of the impedance very fast, it's very important to be a good point of view that you are making, for example, perforation or something like that. Change of the impedance sudden, it's an indicator that you have made some trouble. So take care of this area. ECMO can be an alternative in severely depressed LV function. If you are, for example, as I told, intolerable VT, try to make substrate mapping. As I said, smart touch catheters, it's very important to identify the pressure, tissue contact, and good ablation points, especially the stability. Okay. I will give some hint about epicardial ablation and what's called dry pericardial puncture. It's sometimes some difficult, but it will be easy if you are getting the strategy or protocol that I will give. Okay. Transthoracic pericardial approach. Okay, the most common one that you are doing in the epicardial zone through the subxiphoid space, and we are trying to avoid RV puncture because in this case the pericardium is like the visceral pericardium and the parietal pericardium are totally adherent to each other, so we are trying to less avoid bleeding either in the RV puncture or vessels or sometimes the liver injury itself or vessels of the diaphragm. Aspirated pericardial air will be connected by the zone itself. So to avoid the effect of external DC, if you are getting much air inside, if the patient developed the VF or something like that. So what is the dry pericardial access? Avoid bleeding before procedure to get bleeding during puncture. Anatomy orientation, like CT, MRI, echo to identify. Fluoroscopy points, all the time I do it in the EB or lateral view to be sure that you are getting epicardial, not RV puncture, for example. So there is two techniques most probably used, either contrast dye injection or guide wire probing. This is, for example, the access during dye you are getting the lateral views that I use here, and you are all the time just minimal moving the puncture and giving dye minimal amount until you reach the best point that you have, like for example, popped inside the space and trying to get the wire, and trying, when you are doing this, try to use the wire with the needle itself attached to the electrical activity. So when touching the myocardium, RV myocardium, it will give signals or can induce the F, for example, the F. So be sure during the puncture to avoid electrical stimulation of the RV that will be found during the puncture itself with the needle. Sometimes we use what's called soft wire probing technique. This is sometimes I use the needle for example, spinal. I use the time 22 gold. I will use it inside the puncture that I use it for access assembly. I use it 22 minimal with minimal soft wire that will give you space, and when you are identified, you will exchange the wire with different wire. Okay. As it said, the complication that we have talked about, and the precautions all the time during mapping, 1 ml, not 2 ml as previous seen, 10 to 17 ml during ablation. Try to distance from 5 millimeter between the coronary arteries, especially if you are ablating near the, for example, septum or near the anterior myocardium itself, so to avoid LAD injury or something like that. Coronary angiography should be done and both like as a map during ablation to avoid nearing ablation. Sometimes the cryothermal ablation can be used. Pacing maneuver in the epicardial space are totally different. You are giving high output all the time to ensure lack of phrenic nerve capture to avoid ablation them. Conscious sedation or general sedation or general anesthesia. The sheath and balloon. Sometimes I use it to avoid ablation of the phrenic nerve. So for example, I am near to the phrenic nerve. I will put, for example, balloon to make the pericardium free from each other. The visceral and the parietal pericardium are far from each other by using this balloon. So you can ablate and you are trying to avoid ablation of the phrenic nerve itself. Trans-venous epicardial approach, that's using the coronary venous system, like the coronary sinus and the branch of the coronary. And this is sometimes done, for example, in the LV summit, PVCs, or for example, LV crux that can be used as a mapping from the coronary sinus itself. And sometimes it's difficult because of the impedance are preventing you. In these cases, you will use larger irrigation amount to, for example, give better energy in less amount of time. So like you are hit and run in these cases. And trying to avoid ablation of the vessel itself. So you are not trying to get ablation of the artery itself, but you are trying to side the vein and more directed to be away from the artery by when you are doing the coronary angiography at the same time during ablation. Avoiding phrenic nerve, especially if you are ablating near the posterolateral branch or something like that. So you are trying all the time to use soft mapping catheter, like for example, stereotaxis catheter. It's easy to be used. Irrigation lumen of the ablation, as I said. Try to avoid small branches because it will not be able to ablate during this zone because of the high impedance that will happen and the temperature. Sometimes you will need cryothermal ablation, especially in the crux or sometimes near the coronary artery itself. For example, this is case I have mapped just a few days ago. It's in the LV summit near the anterior cardiac vein and near the LAD, and it was good ablation by using 20 using 20 watts at irrigation about 35, and I have done it just 30 seconds and the PVCs have disappeared at once. So sometimes you need to give contrast to identify the anatomy of the coronary sinus. Is it possible to get inside and map? For example, when you are using the ablation, try to avoid coronary arteries by doing coronary angiography before or need during ablation itself. Sometimes the impedance can be the problem during the ablation. Cooling, as I said, by giving larger amount of irrigation during ablation. So these are the criteria that you are trying to get during ablation of the epicardial zone. Okay, here are getting the ideas again. Setting before the ablation, protocol identification, identify the anatomy before ablation, coronary angiography, it's very important, the epicardial zone or coronary epicardial transvenous ablation epicardial. Try to identify alternative solution, especially if intolerable VT. Imaging, especially if you are using CMR before ablation, it's very important sometimes in, for example, non-ischemic cardiomyopathy or dilated cardiomyopathy to identify the scar that you are targeting during ablation to avoid much time wasting during mapping. And it can be, for example, incorporated during the ablation and identify which zone that you are going to ablate without less much time to waste. This is all the information that I can give about the tips and tricks during ablation, and I'm ready for any questions later on. Thank you.
شكرا جزيلا. احمد طه، معاك الدكتوره ميرفت ابو المعاطي.
دكتور ميرفت، اهلا بحضرتك.
اهلا بك. انا دخلت متاخر بس لظروف يعني خاصه كده. اول حاجه طبعا الابيكارديال ابروتش، شكرا جزيلا لتوضيحه، ولابد ان حد يعني يتدربوا عليه. انت ذكرت حاجه مهمه جدا اللي هي ان انت بتستعمل تو فيوز، الاي بي فيو والليفت لاترال فيو. الليفت لاترال فيو ده جميل جدا لان انت فعلا بتشوف الاسترنم وبتشوف الابره وهي داخله، لان ساعات احنا في الاي بي فيو بنلاقي نفسنا واطيين قوي، يعني في ليفل قليل، فبنضطر نطلع فوق شويه. المشكله بتكون مع العيانين الاوبيز اللي الابدومن بتاعهم كبير قوي. لما بيحصل ان العيان اوبيز قوي ممكن نلجا لحاجه ثانيه اللي هي ابيكارديال ويندو، والجراحين بيعملوها بمنتهى البساطه والسهوله، والجراح بيفتح ويعمل اكسبوجر للبريكارديوم ويحط لنا الشيز بتاعنا ونشتغل. ودي اضطرينا نعملها في احد الحالات اللي احتاجنا نعمل ابيكارديو، والعيان كان اوبيز جدا، وكان الريسك ان احنا ندخل بالابره وبالكده كان فيري هاي ريسك على العيان نفسه. واتنقل العيان من اوضه جراحه صدر القلب، كان في عين شمس تخصصي، للقسطره اندر جنرال انستيزيا، وطبعا كان التخدير معاه يعني حتى ما فوقناهوش ورجعنا نيمناه تاني، بالعكس جه على نفس التخدير بتاعه مع فريق التخدير، نقله لنا من اوضه العمليات جراحه قلب وصدر الى اوضه القسطره، وكملنا له الابيكارديال في تي ابليشن. محاضره جميله دكتور احمد، وانا بشكر الدكتور نور الدين، هو معانا هو برضو. دكتور نور، انا بس اسفه جدا، كان عندي ظروف عطلتني عن ان انا اكون معاكم من اول التيتشنج، وانا فتحت لكم الفيديو بتاعه كمان.
شكرا. انا بتاسف، انا محاضرتي ما كملتها، صار كونكشن بروبلم، يعني اذا الوقت مو متاخر فيني اعمل يعني
اكمل طبعا
الليكتشر.
يس اتفضل. من حظي ان الكونكشن باظ معاك.
بعتذر مره ثانيه، بعتذر كثير.
اوكي، شكرا جدا دكتوره ميرفت، شكرا دكتور نور. المايك مع حضرتك.
اوكي. شكرا كثير دكتور طه، المحاضرة أكثر من رائعة. So I will continue my presentation. So with the case, our patient is a typical VT patient, 77-year-old man with ischemic heart disease. Last year he had posterior wall myocardial infarction, and he had at that time a late presentation in our hospital. And he had already a PCI and stenting in the RCA, LVEF 30%. And 6 weeks ago, 6 weeks after that, he had his ICD implantation. And he had also 2 episodes of VT last year. That's why we tried amiodarone, but amiodarone had to be discontinued due to some side effects. So I will talk about a little bit about the mechanism, ablation strategies, and timing of ablation. Many of them, they were very well presented by Dr. Ahmed. That's why I will not talk about everything in details. So I will skip that. So again, why we differentiate between VT patients in ischemic heart disease and not ischemic heart disease. It's all because of the scar. The scar in ischemic heart disease is usually near to the epicardium, to the endocardium. Actually, in most of cases, it's subendocardial. And in many cases, so especially in very old patients, before the era of before of stenting and PCIs, we used to see a lot of dense scars, and now we are performing a lot of CTOs and a lot of coronary angiogram, and we see now a lot of complicated scars with too many islands. So we have a lot of survived myocytes, which with slowing cell-to-cell connection, and this slowing cell-to-cell connection, this exactly what creates the zone of slow conduction, and with what creates the critical isthmus, and what creates also in its role the reentrant tachycardia, like in this case. And our goal in the 3D mapping to identify where is this critical isthmus. However, if we want to make activation map, it's like Dr. Taha, he explained all of these things very well. We are able to find mid-diastolic potentials and to make concealed entrainment. Here is an example in this patient. You see here the scar area, and this is the potential what we have seen during sinus rhythm, and this is the ablation catheter, and this is here the ablation catheter. Here is the scar area, and we see this nice small late potential. However, in this place, during the VT, we see these potentials. And these potentials, actually what we call mid-diastolic potentials. However, be cautious when you see in some papers or in some books, presystolic potentials or mid-diastolic. These names of potentials are very controversial, and it's very different between author to author. You have to be very cautious. But however, in my opinion, mid-diastolic potentials is the most correct name of these signals. However, what we see here, we see a concealed entrainment. So once again, concealed entrainment, we have to see always 3 points for concealed entrainment. When we are pacing, so the paced QRS looks exactly the same like the clinical VT. So we have the same paced QRS. This is one criteria. And if you measure from stimulus to QRS, it should be about the same if you measure from the EGM to the stimulus QRS. And the post-pacing interval should be also about the same like the cycle length of the ventricular tachycardia. However, activation map in VT can be sometimes very very challenging. Why? Because we have a lot of VTs which are not tolerated, not inducible. We have a lot of VTs which are, so the patient is sleeping due to propofol.
دكتور نور
and
ممكن
the VT
ممكن اقطعك دكتور نور بعد اذنك، ممكن السلايد اللي قبل دي بعد اذنك.
okay.
سؤال، لما حضرتك بتعمل الانترينمنت، لما هنا انت وقفت، اولا طبعا لازم تتاكد ان احنا انتريننج، وان احنا مش بس، وان احنا طبعا السايكل لينس دي دريفن نفس بالترين. طيب لما حضرتك وقفت البيسنج بتبص على الريتيرن اوف ذا بوتنشال اللي هو ده بتقيسه ده صح؟ بس عشان عايز اوضح للشباب، يا شباب انت بعد البيسنج سبايك بتقيس، مش بتقيس الكومبلكس بقى، بتقيس البوتنشال اللي ظاهر على نفس التشانل. اوكي، اللي بتقيس منها بتقيس منها، يعني هو هيقيس من اول السبايك دي، امشي بالعلامه الحمراء بتاعتك يا دكتور نور، على روح بقى ايوه لحد هنا عشان يقيس البروبر بي بي اي. وهو كمان بيشوف المسافه من السبايك للكيورس كومبلكس، يلاقيها هي نفس المسافه ما بين الميت دايستوليك بوتنشال والكيور اس كومبلكس. لكن انت طبعا بتبيس 30 ملي سكند less than the tachycardia cycle length. You have to make sure that you are in training، ان انت مش مجرد السبايكس دي في الهواء وان هي مش بتاثر فيها وتقوم تلاقي يا سلام البي بي اي دي قد التاكيكارديا وتتخمم فيها. بس شكرا يا دكتور نور، انا بس كنت عايزه اوضح للشباب الحته دي.
طبعا مشان نتاكد بالضبط انه فعلا انه we had entrainment or not. For example, in this case, it's very helpful to measure in the RVR in another catheter. So from here to here, it should be the same cycle length like stimulation cycle length. يعني أنا بقيس من هنا لحد هنا ومن هنا لحد هنا. It should be exactly the same. It should be 520, for example. And if it's not, it means we didn't have entrainment. Okay. We have also some challenges with activation map. Sometimes we have, or not sometimes, it's very often, we have multiple monomorphic or pleomorphic VTs. And in this case, we have to perform substrate modification. So substrate modification was very nicely explained by Dr. Ahmed. Here, an example, or actually this is the substrate or voltage map of this patient, which was presented. What we see here the scar. The voltage setting is between 0.5 to 1.5. We have these numbers from the working group of Mashinsky about 20 years ago. Look here the points. This is a point-by-point map with Carto. Abel means the ablation catheter, and C, please, the EGMs of the ablation catheter. It was measured by 3.2, so it's above than 1.5. It means we have here a normal voltage. So, and here in the dense, in the area of the dense scar, we see this nice fractioned potential. It's very nice, and the late potential is very, very late. And we measured here about 0.2. It's very, very low. That's very typical. And very important also to see the points and the EGMs in the border zone. The border zone is the zone between the dense scar and the normal voltage. And border zone is the most problematic zone actually. So that's where we expect that the channels or the exit and the entry sites are located. And in this place, for example, look here. We see also late potentials, but they are a little bit bigger than in the dense scar, and they are not that late like in the dense scar. Very, very interesting. So, if we want to ablate, we have to define the scar, and then we have many strategies. Dr. Ahmed also explained very well. I will also talk about that, but very shortly. We have the conventional isthmus. For example, we see here where the isthmus, and then we ablate here. That would be very nice, but it's not very easy to identify all the time. Or we try to identify where are the border zone exit sites, and we ablate that. This strategy has a lot of names. It depends on the author. So once more again, for example, in many cases, it would call just border zone exit sites ablation, or the channeling or ablation of channels. However, when you see the channeling or something like this, so this is the strategy what is meant. And we have also the scar homogenization. It means we look for all late potentials, for all lavas, and we ablate all of them. And the last strategy is scar isolation. Scar isolation is very controversial. I will show you one case now. So once again, substrate modification, it means it's a voltage map during paste or sinus rhythm. And we also try to understand the scar and to identify channels, lavas, border zone, etc. And please remember these numbers of the setting of voltage from the working group of Mashinsky.
ثانية واحدة يا دكتور نور الدين. What is the voltage limit في الابيكارديال mapping؟
Epicardial 1.0.
1.0 لكام؟
لا till 1.0.
لا يعني هنا من 0.5 ل 1.5. الابيكارديال من كام لكام؟
As 0.4 till 1.0.
من 0.4 to 1.
to 1.
شكرا دكتور نور.
بس هي epicardial bipolar يعني.
طب how about unipolar endocardial؟
unipolar endocardial هلا في there are many datas يعني general 8.5 or 5.5. It depends on also on the authors. What I use is 5.5. However, unipolar is not that exact and not that precise.
Okay, the range of unipolar أعلى higher than the range for voltage.
هي دائما بينصحوا انه low border, but however in most of cases this number is not that important. This number is very important. The high border. So generally it's like the high border is important. And also one more, I have some colleagues who are trying to play with these borders all the time, because if you look to the work of Mashinsky, he says the really normal, the very, very normal myocytes, they should have voltage more than 3.5. So it means you still have some myocytes which with or some zones with voltage of 2.0, for example, but they are very fractioned and they still may be problematic. Who knows? So these numbers is also sometimes controversial, to be honest.
شكرا دكتور نور.
So again to our patient. So in this case, we had, so the patient came with VT, which was recorded in his ICD. So we didn't have any ECG documentation. And we knew that the cycle length is between 540, 550. So it's not very fast. However, during the EP study, we were able to induce 4 VTs. And 2 of them, they were very fast. And this VT1 was very dominant during the EP study. So this one was very dominant. So we tried to make an activation map of the VT1, but it was not possible because it was not very sustained all the time. However, near to the border zone, like you see here, we had a perfect map, pace map. You see here the best QRS looks exactly the same like the clinical VT. This is one point. The second point is, if you look from the stimulus to QRS, it's long. It's also important. That is what we have seen during the EP study. We have seen these nice diastolic or mid-diastolic potentials during VT, and when the VT and in sinus rhythm or during RV pace, we were able to see these small late potentials. So when you see such potentials, it's like these potentials are shouting, "Please ablate me." And here again, the same thing. However, that's what we did, what we have done at the end of the procedure. Was long procedures, about 3 hours, 2 hours of ablating. So it's very, 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 how you say, so a lot of ablation points. And that's what we called homogenization. And at the end, we tried to induce the VTs. We were able to induce the fast VTs, but the slow VTs were not inducible. The slow VTs were not inducible anymore. So the slow VTs were our clinical VTs, and we decided just to finish and to end our procedure. This procedure was performed about 6 months ago, and I didn't hear anything from the patient. So I hope he is still free from this slow VTs. And what about the fast VT? I don't know. I hope he will not get them. But you know, that was our point, our end point. We didn't. We were not able to induce the clinical VT. Then we ended. What about scar isolation? This is another patient. You see here a very big scar. The scar is apical because the patient had a huge apical aneurysm. We put lasso catheter in the aneurysm. honestly, usually we don't do that, but for this case, because we wanted to publish this case, and that's why we have done that. If you look at these potentials before ablation and during ablation, we started to notice that these potentials are getting later and later, these late potentials. So it's that remind the pulmonary vein isolation. So the potentials, the late potentials are getting later and later. And here, still later and later. And that's what we've got at the end. The scar was isolated, and here we have automaticity. The exact thing what we see during VT or PVI, the exact thing. However, that was very, very, very nice. If you can reach scar isolation, it's great. But believe me, it's very, very difficult. In this case, it was not that difficult because the tissue in the aneurysm area, it was thin, but normally to isolate ventricular myocardium is very, very difficult, and it could. I would not advise to do that as a standard, maybe in selected cases like this case, but not as a standard. So we have here a trial from DiBiase, and he compared ablation of stable VT, so activation map, to substrate modification in ischemic cardiac disease, and those patients who had undergone substrate ablation, they had less VT recurrence than patients who had undergone mapping, activation mapping. This is also a very important and very nice trial, SMASH VT. We had patients who had VT or syncope with inducible VT in the EP study, and we had then the patients were included in two groups. The first group, they received only ICD, and the other group, they received prophylactic VT or VT ablation and ICD. However, patients who received ICD and VT ablation, they had less VT, less ICD shocks, less VT occurrence. But there was no change in survival, unfortunately. Dr. Ahmed also talked about that, about the new approaches in the future for VT ablation. However, needle ablation and bipolar ablation, in my opinion, is very, very interesting in selected cases, especially in cases with scar in septum. So, my colleagues, I would like to conclude. Scar-related VT after myocardial infarction is the major cause of sustained monomorphic VT. Catheter ablation is a highly effective method, but it does not replace the ICD therapy, and it does not avoid sudden cardiac death. The ideal time for ablation is still not clear. After the first VT ablation, after the first ICD shock, or after trial with amiodarone or something else, we still don't know. And thank you for your attention. I will be happy to hear your questions.
شكرا جزيلا دكتور نور الدين، محاضرة جميلة. وعايزة برضو I want to stress upon the last point which you mentioned ما يجيلكش عيان بفي تي اسكيميك في تي او دايركت كارديوميوباثي ويقول لك يا دكتور لو سمحت خش اعمل لي ابليشن، انا مش عايز اركب اي سي دي. هتقول له لا، لان دي بتحصل الايام دي كتير. الابليشن الناس دلوقتي عرفوه والدكاتره الحمد لله يعني اوير بيه، فما ينفعش ان انت تطوع العيان. ما تطوعش العيان، انت هتقول له الصح. الاي سي دي ده لايف سيفنج، وبعد كده الابليشن دي تو مينيمايز ذا اتاكس، تو مينيمايز ذا شوكس، تو بس. لكن حتى هي في الاستادي اللي هي سماش في تي دي قالت ان الفي تي ابليشن، الايرلي في تي ابليشن ما بتاثرش على السرفايفل لان الميوكارديوم فيه مشكله. ولو ان طبعا في استادي ثانيه ما اعرفش اسمها ايه دلوقتي اللي عاملها كارل هاينز كوك.
برلين في تي.
ايوه برافو عليك، انت مذاكر اهو، ما انت من المانيا صحيح. هم دول بقى يعني الوحوش بتوع الشغل. فكارل هاينز كوك قال ايه؟ قال ان الريكارنت ديسي شوك دي بتاثر على الايجكشن فراكشن مايوكارديال. وصلح لي بقى ايه الداتا بتاعته، قولها لنا كده يا نور يلا.
صح بالضبط. هذا كان كمان نفس الفكرة، نفس فكرة سماش في تي، بس لكن يعني بصراحة يعني عندي تحفظاتي بالنسبة لهي الترايل. يعني it's not enough empowered like smash PT، بس يعني النتائج تقريبا نفس الشيء.
يعني هو قال ان العدد الديسي شوك اللي بياخدها العيان من الديفايس بتاثر على الليفت فنتريكل فانكشن، فبالتالي هو لما يكمل في تي بدري يمنع القصه دي فيحسن من الفانكشن. ده صحيح؟
ده صحيح.
اوكي، طب يبقى انا كويس، ذاكرتي طيبه. يا شباب حد عايز يسال الدكتور نور حاجه؟ انور.
نعم بروف، السلام عليكم.
عليكم السلام.
ازيك يا انور؟
ازي حضرتك يا بروف، ربنا يخليك. انا
آه.
كنت عايز اسال دكتور نور، هو كم يعتمد البتر ماتش في البيس مابينج؟
كم يعتمد شو؟
بيقول ثانيه واحده عشان اوضح السؤال. دكتور انور بيقول لك يا نور انت بتعتمد على الباترن ماتش كم في المية؟ مش ده سؤالك يا انور؟
نعم بروف.
طيب.
يعني بالنسبة لي يعني the more the better، بس أنا بالنسبة لي يعني كل شيء أقل من 93 95% يعني 95% وفوق، يعني هي هي الإيديال
95 وطالع يعني.
صح.
98 افضل، 100% افضل. طبعا مفيش حاجه 100%، بس صح. هي 98 95 يعني من 95 وطالع.
نعم بروف، لان احنا في يعني النورمال هارت يعني 97 98 دي يعني بيرفكت. يعني بالسكارليتد في تي هل البيس ماب يعني ننزل 95؟ اوكي، يعني هي طبعا اكوردنج للاوبريتور. يعني في بعض المرات احنا بنشوف الاكسس اوف اي سي جي وكانما 12 اوف 12، لكن بيختلف الفولتج ويختلف في الترمينيشن بتاع الكيو ار اس كومبلكس. اوكي، فيعني حضرتك تعتمد اقل شيء 93؟
لا قالك 95.
95 اوكي.
95 بصراحة، وكمان تعتمد على حسب السيستم اللي عندك اياه. يعني ما بعرف انت بتستعمل انت شو السيستم بتقيس فيه نحن عملنا مقارنة بين بين الباسوميب بالكارتو وبين البارد، والبارد كان أدق. البارد يعني هو مانولي بس كان أدق من الكارتو. يعني 93% بالنسبة لي في البارد أفضل من 97% بالكارتو يعني. بس هي يعني
البارد
يعني
اول ناس عملوا الباترن ماتش عشان تبقى عارف.
صح.
فبالتالي هم عندهم الالجوريزمز بتاعتهم اقوى. والبارد بيعتمد ان انت اللي بتاخد السيجنال وتحطها، مش كده؟ اما الكارتو ده اوتوماتيك، ده حسب ما انا. تمام. انا كنت هسالك حاجه يا نور على الاتش دي جريد. هل وجدت فروق في استخدام الاتش دي جريد عن البنتاري في المابينج والدقه الليد بوتنشال؟ مين فيهم احسن؟
الاتش دي جريد برايي هو يعني فعلا في فرق، افضل من البنتاري اذا نقارن. يعني انه مولتي الكترود كاثيتر بالنسبة لي أفضل. السبب هو إنه الارتيفاكتس أقل. البنتري بيعطي كتير ارتيفاكتس خلال الميبينج، فالبنتري أفضل. لكن الكارتو للفي تي، الكارتو بصراحة أفضل، لأنه يعني patients with VT should يعني غالبا تعملي defibrillation. فإذا عندك السيستم هو inside precision، للأسف في مشكلة الماب شيفت. الماب شيفت بال inside precision هو مشكلة كتير كبيرة. لا إلا إذا عندك الانسايت اكس the new mapping system and HD grid is better. بس ما بعرف بمصر اذا عندكم انسايت اكس او لا. راح
تمام يا شباب.
Actually, I use Insight X myself. I don't use Carto because I'm more acquainted with Insight X. That's the system I use all the time. Carto, it's not all the time I use it, so most probably Insight X, even the map shaft and some changes, I try to be more accurate in doing the map itself. Like I do it once, twice, and third, and all the time I try to take the mean every time.
صح. انسايت اكس سيستم رائع بصراحه. لكن اذا انتم لاحظتوا انا الماب اللي هون عملتهم، هذا الماب هو بوينت باي بوينت.
يس.
هلا بصراحه في كمان هي شغله انه الفاينانشال كوست. يعني هلا مثلا هون انه بس كاثيتر واحد وارخص بكتير، بس لكن تطول اكثر بشوي صغيره. يعني هي شغله يعني مثل ميزان، يعني بدك في شيء احسن من احسن. دائما في مجال كتير للنقاش انه احسن ملتي الكترود سيستم ولا نوت ملتي الكترود سيستم.
You're right. HD grid I have used many times and it gives me maybe shortening the time, but not so much shortened if you are not accounted with it. Sometimes it becomes need to do remapping with point-to-point mapping after using HD grid to be accurate of the point that have been taken, for example, or acquisited. I think this is also like confirming of what's have been done with the HD grid, for example.
HD grid, I love HD grid. In my lab, we performed already about 400 VT ablations with HD grid. I'm very satisfied. But for example, if I want to perform VT ablation in my home country in Syria, and if you tell the patient, okay, you have to pay
It's impossible.
euros for HD grid, I don't know if it's a very good idea, to be honest. That's my opinion. In Germany, okay, the insurance is paying for everything, but it's still very expensive, unfortunately.
Yeah. Just one comment for the Basumab or, for example, the base mapping. As I said before, even if you got, for example, 12 by 12 ECG and sometimes 11 by 12, I have 3 other integrated points: the stimulus to QRS complex in compared to the local EGM to the QRS complex. And second important thing, if you are doing, for example, in the isthmus zone or inner loop or something, it can give different, sometimes morphology difference. But as I said, the initiation of the QRS complex, for example, like ascending limb, can get more information about it. For example, if the ascending limb is very slow, it means that you are in very late potentials, like slow zone, very slow zone. And this is very, very important point of view. In these slow zones can be good point for ablation, even it's a corridor, for example, in the entrance point or something like that. So not only the 12 by 12 or the QRS complex itself, but can be also the intrinsicoid deflection, for example, and the axis itself, how much the axis are compared to the axis. So it's like integrated parameters, better than one parameter you can evaluate through the BASO map or something like 12 by 12 base mapping.
Exactly.
Okay. Dr. Anwar? دكتور ميرفت؟
نعم يا دكتور أحمد، شكرا جزيلا دكتور نور الدين، وشكرا جزيلا دكتور أحمد طه، المحاضرات رائعة جدا جدا. شكرا جزيلا دكتورة إيمان على التنظيم، وشكرا جزيلا أستاذ علي وللحاضرين، ودمتم بخير، تصبحون على خير.
صباح
شكرا
الخير.
جزيلا.